Hello, everyone. Welcome to Accountable Hindustan's podcast, where we explore bold ideas, innovative solutions, and impactful conversations that drive change in India's healthcare, education, technology, and policy landscape. I am your host, Dr. Gnaneshwer Reddy, and today's episode is one that's close to my heart, healthcare digitalization in India. We often hear about India's booming healthcare sector, yet millions still struggle with fragmented medical records, inaccessible health data, and inefficient hospital systems. The question is, can technology fix this, and how we can ensure healthcare data is accurate, accessible, and truly beneficial for both patients and doctors. To help us answer these questions, I have very special guest today, Siddharth Ramesh, the founder of Medblocks. Siddharth is revolutionizing healthcare IT platforms more accessible, interoperable, and efficient. His work aims to empower developers, hospitals, and policymakers with the right tools to create a connected healthcare system in India. That before we get into, from your perspective, what are India's most pressing healthcare challenges today?
Gnaneshwer, the first thing to keep in mind is the incentive models in place. Any healthcare system doesn't operate in isolation. You usually have a public sector and a private sector. And in India, for example, almost 90% of care, if someone can afford it, would go to the private sector. Although the public sector by numbers may still be serving a lot of people, the default option that someone chooses is usually to go to the private sector because the public sector is underfunded. If you've been to a public government hospital, you would probably know this. So what happens is that in the private sector, the main mode of someone operating is fee for service. Okay, so it's not just fee for service; it's fee for doing something usually. So what, for example, we run our own ophthalmology clinic. Both my parents are ophthalmologists. I took a look at like how much someone pays for the consulting charges and how much someone actually pays for something like prescription glasses or getting a surgery done. Almost 90% of a hospital's revenue, if they're able to do surgeries, comes from procedures. If a medical center admits patients, 80 to 95% of their revenue comes from admitting people. I think the main challenge right now is there is a disconnect between what is really good for the patients and what is good for business. And since most of healthcare is privatized and everybody is in it, it's not that I know for a fact that a lot of people look at it as a service, venture capital led industries. We are seeing a lot of these. We are seeing, I don't want to name names, but I think if we don't, then we don't get anywhere. But for example, we are seeing Pristine Care. We are seeing other people like Practo who have burnt their fingers here, right? They have attempted to do healthcare, but it has turned into more and more of how can we cut corners? What can we do to make more money out of each transaction? Some people are downright doing things that are unethical, right? Which is diagnosing people with things that they don't have. We know for a fact that there are some doctors who diagnose people with cataract and then do cataract surgery on them just to meet quotas. The patient has no need to get that done. We are seeing people admit people where it's not necessary. And what happens here is that it starts building this mistrust in the patient's mind on, is this doctor doing what is right for me? And there are going to be some hospitals which always have some quotas and they have to meet those quotas, and the doctors, even though they might be incentivized to just do the right thing, they are kind of incentivized and pushed to just prescribe that one more extra thing or just do that one more extra procedure, which again, like doing a cataract surgery and removing someone's normal lenses for an intraocular lens, it doesn't cause much harm, but it's unnecessary and they're doing it for that increase in profits, right? So we are seeing this, the market today, this is what we have today. Okay, like we need to come to terms with that. there are still a lot of good ethical practices which think about what is good for the patient and they do it as a service. But then if they are doing it because of the good in their hearts. So for example, if you take my parents who have been ophthalmologists in Tamil Nadu, Karur for a very long time, they are very, very upset with other ophthalmologists doing this. They see that it's completely unnecessary and they are not doing the best of care. They are still bound by this moral code that they are not going to do what's not necessary for a patient. But then there is no legal structure around this. There is no incentive model around this. And people, as they see that, hey, we can get away with this, we can make more money, it's inevitable more people start tending in that direction.
As you mentioned about the disparities in healthcare in India, where do you see the biggest gap in patient care, especially when comparing public and private healthcare?
In an ideal world, we need to think about the patient as a whole. Consider the long-term health of the patient. You shouldn't treat them only when sick or when they want something. You should consider, what can I do to prevent something? What can I do to... So for example, let's take an example. So if someone has diabetes, right? And then they let it go on for a very long time, they'll have complications like you have diabetic retinopathy, you have diabetic foot ulcers, you have like just chronic kidney disease, so many diabetic related complications. It's easy to control it when it's early, okay? So it's again another example as well, which is, let's say you just get someone a toothbrush and they're able to brush every day. Right? It's easy to prevent caries. It's easy to prevent them from going and getting a root canal treatment because it went too far. But because of the incentive models around care right now, so because we are seeing that it's mostly fee for service, hospitals and private institutions, these are like 80 to 90% of the care that is being provided. What happens is, what is in it for them if they give a patient a toothbrush instead of a root canal treatment? They are going to basically not get that treatment done. What is in it for them if they check in or call up a patient with diabetes and make sure their sugar levels are under control? They are not going to get diabetic retinopathy. They are not going to get diabetic nephropathy. But then since their whole financial model revolves around services, admissions, and prescribing procedures. This is why I think we are seeing new models emerge. We are seeing care providers also offer a sort of an insurance plan. We are seeing new healthcare startups who are collecting a subscription from their patients, and they are promising that all care delivered is free. It comes with a subscription. We're seeing direct-to-provider care models where patients pay a subscription to hospitals to keep them healthy. They don't pay anything for the services, but then they pay to take care of all of their conditions. Now, this shift is going to be really slow, right? So because people still don't understand, for a hospital to think about long-term health of a patient, you cannot have fee for service. These two models are like at opposite poles. You cannot have both. You cannot ask someone to just pay for doing a particular service and think about long-term health of a patient. You're fighting the financial flow.
So one of the biggest frustrations we hear from doctors is they often must treat patients without complete medical records. How important is accurate medical or health data to improve patient care?
So here, it's actually, I have a mixed opinion here, right? Like again, it really depends on what kind of care you're providing. So if you are doing transactional care, right? If you only care about the current procedure that you need to do, right? You're just looking at what does the patient need right now. So a patient comes to you, you're like, okay, what's your problem? They tell you something, you're like, okay, this is the prescription for this is the particular procedure for this, go out there, this, right? So the infrastructure or the digital infrastructure needed is minimal, right? Paper notes. You can have people come into your clinic, you can just write something down, you can just make sure that's okay, and then you let them go. The only reason why someone cares about their previous medical history or previous medical records is so that they can check for other risk factors, other conditions. Okay, if they have diabetes or if they have hypertension, then before they take them up for surgery, we need to make sure that all of this is controlled. Okay, so it's like avoiding the risk of something happening. So again, it only makes sense. The digital infrastructure and the longitudinal health record of the patient in place starts making sense once you want to provide holistic care of the patient's health journey. You want to prevent things before they happen. You want to check in on the patient before they are admitted to the hospital. You want to see what you can do so that they don't have to come to the hospital in the first place. Yeah. So with these emerging care models, with these new sort of like subscription-based models, need a data infrastructure. They need, so we're working with a lot of other startups. Like we are working with one called Clinic, CLINIKK. They are doing excellent job. Here in Bangalore, they have a lot of actual physical hospitals. Their patients pay them a subscription fee, and we help them with digital infrastructure for health records. And it works for them because they are collecting all of this information so that they can provide the best possible long-term care for their patients, for their subscribers, to make sure that they stay healthy, they track their they track their wearables, they track their everyday data that they can enter in their PHR, in personal health records. And all of this then starts making sense if you look at the patient in the holistic view, right? But that coming up only when you move away from this transactional care paradigm, where you're like, okay, you have this one condition, I want to treat you for this one thing. In this paradigm, you just are concerned about the risk factors that you need to control. You're not looking at the past history so as to provide a better overall holistic care. You're looking at the current problem, you're just solving the current problem, and then they go back, right? There is not much follow-up, there is not much, like we are taking care of you for the long term. It's mostly, you're coming to us, we are giving you a solution, go back, right? Pay us, and it's done. It's almost going to a shopkeeper and buying a particular product.
What happens when medical records are missing or broken? For example, one patient is moving from one hospital to the other hospital. So the clinic you mentioned, one of the example is they are recording all the data of the patients, but the patient doesn't want to go to the same hospital. He wants to go to the different hospital next time. Does the patient has to carry all the medical records in the physical form or digital form to get better treatment in the next hospital when they visit?
In the Indian context, we are seeing new digital initiatives. ABDM, or Ayushman Bharat Digital Mission, is one such initiative where you can digitally transfer data from one hospital to another through the consent of a patient. However, each patient needs a personal health record app downloaded on their phone, and they need to allow the consent to actually make this data movement possible. And a lot of patients today are still not that informed that they download an app on their phone. Most don't have a smartphone. Smartphone adoption is increasing. People have smartphones, but then for them to understand that there is an app that they have to download and they have to allow consent, it's a little too optimistic in terms of the implementation, right? So we are still seeing like there has been a lot of incentive schemes around this. Even the government is paying you if you create someone's digital health ID, and then this digital health ID is unique and it's UPI where you can quickly send data from one person to another. But again, the complexity here is quite a lot, and at least right now we're starting to see at least PDFs being transferred from one place to another. Soon we'll start seeing more and more structured data, but then it has to be implemented in a way that actually makes sense for the actual patient. And right now, unfortunately, it's a little bit of a hit or miss, right? So not a lot of institutions are adopting it because they're like, we are not going to get the data. Most patients don't have the PHR app installed. They're not going to give us consent. And then the whole flow that you need to get this done is like, you need to get 2 OTPs, you need to get some multiple, like it's a whole thing. Okay. There is this infrastructure being built by the government, ABDM, Ayushman Bharat Digital Mission. The second one is NHCX, National Health Claims Exchange. This is a protocol between hospitals and insurance companies where they can quickly check if this patient is eligible for pre-authorization, if the settlement can be done digitally. There is a push to start adopting this, but the value will be unlocked once everyone starts adopting. In NHCX, the insurance claims thing, they say that the diagnosis codes need to be transmitted in SNOMED CT, for example. So the problem is neither the hospital has the infrastructure to code data in SNOMED CT. Then once you code it, you send it to an insurance company. The insurance company does not have the infrastructure to match this SNOMED CT code against a policy and understand whether they can be pre-authorized or not. Now, this is something that we've already worked with in the US, in the EU. We've done this a lot of times, and it's not trivial. There is a lot of things that go into like actually doing automatic policy checking, auto adjudication, and so on. It's not an easy thing to get right. There is always going to be human oversight. With new digital initiatives, the insurance company might reduce the number of doctors on their payroll from 100 to maybe 5. Right. For the insurance company, I think it makes sense to start adopting this. And maybe the insurance company starts providing software to hospitals to code all of this and then send it back. And that could be a way in which this could be driven. But again, we don't want to do the same mistakes that's going on in the US, right? So in the US, care is driven by the insurance policy you have. It's not driven by what's best for the patient. It's by what can be reimbursed. So I still think there is this divide between insurance companies, and because there is this divide, there is going to be like the arms race, right? The providers are just optimizing for how much more they can bill the insurance company. Insurance company is optimizing for how less can I reimburse. This arms race, and they're both fighting each other. This doesn't work. This just increases costs for everyone. We've seen this happen in the US. It's not a good place to be in. What really works is, insurances and providers coming together and being like, how can we provide the best possible care? How can we reduce the hospital admissions? How can we make our subscribers healthy so they don't show up to the hospital? This needs high amounts of information flowing between one another. So they need that digital infrastructure to actually make this possible. But it is doable. Some are taking the role of both the insurance company as well as the provider. And they are payviders. That's the name of these new fund. Like they're the payers and the providers doing both together. This is the future of how, at least like financially speaking, care should be provided. Like you have a subscription model for a particular person, and then all of their care needs are taken care of. And then the payer and the provider like work hand in hand. Ideally, they are the same organization, and they provide the best care for the patient.
You mentioned Ayushman Bharat digital mission, insurance policies, hospitals, and technology infrastructure in India. Do you still see the gap between rural and urban healthcare because of technology involvement? As you mentioned, that digital adaptation is still going on. In few years, we might see so much of the adaptations in digital care. We will have the accuracy in the data, and you will have the complete profile of the patient. So do you think more like we are moving towards preventive care rather than reactive care?
The difference between rural and urban is stark, at least in India. Most doctors don't want to live in rural areas, and they would rather just go to so because the amount of investment that they've put in to actually get their medical degree, do specialization, and then it's 10 years of their lives. And on top of that, many of them pay a lot to just get their degrees, and it's a whole thing. And if they serve in a rural area, it doesn't make financial sense. Most want better schools for their children. They want a better lifestyle. Most people don't want to go to a rural setting and then serve there and improve the condition there. Most people go to an urban city and then try to open up a hospital. Like if you take a city like Bangalore, I see 4 hospitals per street, right? Like there's like going to be that many hospitals. Whereas in the same density in a rural area, there'll be like 1 hospital for 10 kilometers. So this divide, I think there is a huge potential here for AI and AI assisted nurses to like bridge this gap. So we see this already being done really well by some. So for example, if you take LV Prasad Eye Institute, like LVPI, they did do this camps, they have these rural outposts, they have technicians trying to understand the problem and refer to a central center. Okay. So that is becoming more and more feasible because you don't always need a fully trained doctor. This could be a nurse practitioner. I think the Indian government's take on alternative medicine and other forms of medicine like homeopathy, Ayurveda, to me, it's a little questionable, but then it also makes it possible for these alternative medical people to serve as the first touch point for patients. I think anyway they are providing most of the care, but with some sort of support from a technological system with good AI, with good agentic reasoning, they might be able to make the right decisions that any doctor would. Maybe even like slightly better because they might be able to have that tendency to talk better to patients. They're probably trained a little bit more to understand the patient's problem a little better. Whereas usual Western medical doctors are more about, okay, I just want to solve this problem, whereas opposed to like just listening to the patient and understanding their problem and like empathizing with them. Many of them do, but then I would say it's majority of the people who are able to become doctors or toppers who always just sat down, put their heads down and studied. They're not always the best at just communicating with people and getting their side of the story done well. So they're mostly like they have a lot of ego. They've finished this thing. They've completed this thing. So in a sense, I actually think nurse practitioners, nurses, technicians, and alternative medical staff with the help of AI can really do this role of primary care very well in these remote centers. And then they can form like an infrastructure around that where they push out these patients who are really in need out to the tertiary and the secondary care centers. But still, before we establish that, we need to establish a care model for these people. Who is going to take care of the financial burden of doing all of this? And if we are looking at the proper long-term health of a population, then it has to be either a government or some sort of a collective which is looking at it in terms of a subscription.
Is an interesting way to see that view of a pay for service versus subscription based. So now let's talk about privacy, security, and data ownership. Who should truly own the patient's data, the hospital, the government, or individual?
The data, it technically should belong to the patient, right? But today it belongs to the institute where it's created and they kind of have ownership of this. But if they are opening up a little bit more and they're using some sort of standards to enable the patient to get a copy, then the patient becomes the natural aggregator. It's easier through the patient than through networks that are not having the patient in mind. Okay. If you see the natural progression of what patients do today, right? Like they take a paper record, they have these files, they accumulate all of this, and then they go and they give it to other doctors. So, in a sense, that's already the case. The patients are the custodians of this data and this information. And tomorrow, in a world where it's going to be more and more important for patients to have access to this data in the digital format because patients can do so much more with this data. Patients can understand what is really going on with them, what the doctor has said. They can check against LLMs and they can check against generative AI to understand the clinical thought that has gone into their record. And they can even get a second opinion within seconds, right? If allowed, everyone is going to push their health records into ChatGPT and they're going to ask for something. Like if you think about it today, like there are so many wrong diagnoses that people just live with, and we are seeing so many cases where ChatGPT has diagnosed after 5-6 doctors in developed countries getting the information right. So I think in India, where the doctor to patient ratio is just insane, there are not enough doctors. Most doctors do not stay in India. They go out to other countries like the US or the UK or Australia and then practice there. So there's going to be a huge adoption in these sort of, PHRs, right? Personal health records. And people are going to use AI and people are going to use these agents to really understand what is going on with them and understand what the ideal next step should be. And that, again, that could also be a glue which connects the different healthcare facilities together.
Now let's shift gears and talk about Medblocks. So your company that's tackling these healthcare challenges. And for those unfamiliar, what is Medblocks and how does it differ from traditional electronic medical health records?
It's a technology company, and we do three things. Okay, one, we specialize in health IT standards. We provide training on health IT standards. You can buy one of our boot camps on either like Fire or OpenAir to understand how health IT standards work. The other way in which we make money is through a subscription called Medblocks Sprint. And what we do here is we provide you with not only like the tools that you need to build your healthcare infrastructure, but we also provide you with developers and a team that will build it for you. Once we build it for you, you own it for life. So we don't charge a licensing fee. And I think that's, again, another problem in the current EHR space, who charge a recurring like subscription fee and lock you in. Right? Like you are not able to do what you want, and it's really hard to get out of them once you make this commitment. So I think Medblocks, our idea is that we provide the building blocks, we provide the tools, we provide the services that you need, and you can maybe like work with us for, let's say, 3 to 4 months to build an EHR that kind of works for you. And this need not be an EHR. This could be an insurance adjudication system. It could be a personal health record of the patient. These are all common patterns. There are common tools that we put together, build, and give you. You get to own it for life. You can pay for maintenance if you'd like. But right now we've built an EHR system for a lot of people. Many of them are happy with what they have. Again, it's because we focus on their problems and what they need instead of one generic product that kind of like works for everyone. Because I think healthcare today is still quite diverse in the requirements. And we are working with a lot of governments in the EU. In the US, we have multiple customers. In India, we have our EHR deployed for a lot of people. So we work on a flat fee development model around $10,000 per month. We develop what they need using our once happy, and once they have that, they can either pay for maintenance or enroll their team who is able to maintain it in some of our training programs, so they can take over and maintain the EHR and the health stack that we built for them. So that's what we believe in, like a sustainable data platform that they can use for life. And it doesn't have to be just us that they pay to do this. We are completely okay with them like getting it built by us and then having it. They have the freedom to do what they want with their data. This is what Medblocks does.
So you mentioned about the Open EHR and Fire. You built Medblocks using those two open healthcare data standards. Can you simplify in simpler terms why they are so important?
If you have a phone, download the apps you want, right, to get the functionality that you want. So that's possible because there is a standardized API between these apps and the operating system. Right, so you have all of these apps interfacing with the operating system, and a consistent way to ask for permission. For example, they need access to your camera, they need access to your microphone. So because Android and iOS, they've built this layer, the apps you can like download, you can install apps, you can delete apps, and they keep moving around, and you don't have to change your phone. Right? In healthcare, that's not the case. You know what? If you want a new functionality, you basically have to replace your whole phone. Imagine how crazy it would be if you had to use a different phone just to use Facebook and another phone just to use Twitter, right? It doesn't make sense. But that's exactly how the healthcare IT infrastructure is today. Like you are basically taking a particular product, and that product has all your data. And if you want to move to another product, you either throw away all this data or you try to migrate all of this data using a lot of complex data movement and expensive than the product. And that other product does something else that's like specific. The idea with Fire and OpenAir and all of these standards is that you separate the data from the application. So the data stays in a repository and people are able to interface with it, and these apps come and go. There may be an app for ophthalmology, there may be an app for chronic diseases, there may be an app for tracking if the patients are doing well, but the data stays in the data platform. And you use this data platform to drive your different use cases. And there is like one standard record of where all your data goes. And it's really important to separate this and understand that the data platform belongs to the institute, the hospital. These apps can either build themselves, maybe using help of something like what our team provides, or they can buy from other people who are also supporting these standards. And then they just purchase an app that maybe takes care of vaccination and immunizations. And then they get that use case that they want, instead of replacing a system or putting it like having multiple systems running at the same time which don't really communicate well with each other. So there is like always repeated data entry. Health data platforms allow, it's a 100 cheaper way to build health IT infrastructure. Our focus is for our customers to be able to build something that works and lasts, separating the data from the application and using a platform that's separate from the apps.
AI is playing a bigger role in healthcare now. So, how Medblock leveraging AI to improve clinical decision making and hospital efficiency?
There are various ways in which you can use AI, right? So one of the easiest ways is like helping data capture, helping capture better data. You don't need practitioners to enter codes. You can automatically infer and ask them to verify. You can listen to a patient-doctor conversation and understand what needs to be filled in the clinical notes. Trust but verify, right? One is capturing data. The other is understanding if the data that you collected, what can we do with this data? So there are so many possibilities here. So one is just like verifying if something is according to protocol, understanding if a doctor is doing something supposed to be done or deviating. Maybe an institution has a policy. Since you have all this data in like a particular platform, an AI can easily see what is going on and it can notify other people. It can take action based on what's going on. Right. So that's an AI as a guardrail to people doing the right thing. But then an even more interesting, again, this is a little bit out there, but then it's possible and it's starting to happen. This is like vertical AI agents. So it means is a human using software to do something. A vertical AI agent would not just replace the software, but it will replace the software plus the human doing the work. Right. So if there is a lot of repetitive work somewhere, or it may not even be repetitive work, it may be just something where in case of a PHR with an AI enabled, right, a patient might be able to do a lot of the work that a doctor would be previously required for. Right. Like slowly they are cutting down on the need for going and checking with the doctor every time. PHR, along with the data, along with AI, is able to do so much more on the patient's data and automatically suggest them what to do instead of having them go back to the hospital, go back to the nurse. If you think about how many doctors are some people who actually accept video consultations, the successful ones are like, you just come to my clinic, visit me. And then the patient doesn't want to do that. They just want an answer from home. Hey, doctor, what does this particular lab finding mean? So vertical AI agents is, in my opinion, the hugest potential, but it's also quite scary because we are replacing an entire vertical, not just the software, but the person. This is new and there is potential for innovation. And I think we are going to see more and more vertical AI agents do these things. So for example, an AI could just call you and ask a patient like, how are you doing? Did you take your medications? Did you go in for a check-in? Why didn't you come for this appointment? It could do so much that previously would have taken a human call center agent or someone to do it. But now it's possible to do because it's so much cheaper, right? Like it's already cheaper to use an AI to do like just calling and understanding what the patient wants instead of hiring a person. So it's not that we are replacing a person. We are just doing so much more of what previously would not have been possible, right? You would not have called these patients at all. But now because this, you're able to get more done and provide better quality services to the masses, previously inaccessible, maybe accessible to the ultra wealthy. The things that were accessible to them will now be accessible to the general public. Looking at AI as just a tool or a guardrail is where most people are focusing. I think that has potential, but in the bigger picture, AI can make healthcare more accessible for all.
Looking ahead, digital healthcare adaptation is still a challenge because of the disparities in the urban and the rural areas. So, what are the biggest roadblocks preventing hospitals from adopting digital solutions?
First thing is not just incentives, the financial model and the model of care is not aligned enough with an investment in digital infrastructure. If you and it's okay, some might be okay with a cheap EHR that they get on a subscription and it works for them. But then there are going to be some institutes require more intensive digital innovation. These are the institutions that digital healthcare enthusiasts should be targeting. People who are doing new models of care, people who are like trying to change the status quo. So it's not that I don't think the traditional health hospital or the traditional way in which things are done today is going to adopt digital health as much. They're probably going to adopt like a basic system of record that they can use, maybe a basic billing system, but I don't see them adopting this. New healthcare startups with new care models are going to take this up and provide better care than the current status quo. And that is how I think it's going to like slowly start displacing the existing players. For people working on digital health, think about incentive models, financial models. Does someone need a digital platform with all their data if they're just doing transactional care? Right? All they need is, okay, what is your problem? Here's a solution. I make my money. Done. Right? So this is going to start making more sense once we start looking at the broader picture. How can we keep patients healthy, increase retention? How can we make sure they stay with us and keep paying us because we provide so much more value? These models need digital infrastructure to get this done. So the traditional players who are still fee-for-service transactional, we are seeing adoption of EHRs. They just want a care record. They want to track their metrics. They want to track key performance indicators. That may be where digital adoption takes place. Insurance adjudication and the claims process may be something where people start adopting this. But then I'm most excited about new care models replacing the old properly in a way that makes sense for the long-term health of the patient. It shouldn't just be like taking care of people who are sick. It should be taking care so that they remain healthy.
As you mentioned about blocks as well, you are also working on helping others to build a platform, seamlessly connect patients, doctors, and the other providers. So, where do you see Medblocks in the next 5 years?
We are thinking about doing the same thing at a broader scale, mainly at training and productized services. That's what we are doing right now. We provide our products along with our services so we can actually drive digital innovation and change. So we're probably just going to do more of this, right? Like we are going to help more people do their digital transformation initiatives and actually get change done. And that will also help us refine our tool set, refine our building blocks so that we can quickly put things together better and better for people to come. We open source a lot of this. We make it free for others so that they're able to see the value immediately. And that's basically what we have to do, refine the tools, refine educational material so people are able to understand and maintain this in the long term, and just get more people involved in health IT. Lack of talent is the main reason why there is not that much innovation going on. So if you're able to get someone slightly interested and train them, then you have everything, the ingredients you need, the tools, you have the people who are able to maintain, you have the services that you're able to provide to get things done so people can see a change in digital infrastructure.
Siddharth, this has been an eye opening discussion. Before we wrap up, what's your one piece of advice for young healthcare entrepreneurs out there?
Read this book called The Innovator's Prescription. I would recommend that all healthcare entrepreneurs read this book, especially because it goes into the incentive models I talk about. You need to align your products, services, and tools with upcoming models of care. That's the way that you are going to break the cycle of fee for service and all of these things that don't work, is by showing people how it can be done better. You need to pick a model of care aligned with what you're doing, right? So I see a lot of people who are enthusiastic about just like doing good for the patients and practitioners, but don't consider the broader system in which this functions. I would say read the Innovator's Prescription, understand the incentive models around the healthcare system even more. Like I would say, understand the business of healthcare deeply. And that's the only way that we can make a lasting impact in the patients' lives. Like I say, we probably save millions of lives by writing one or two lines of code, might end up hurting a million people or might help a million people. So I would say understand the business model of healthcare and align your goals with it.
Where can our listeners connect with you and Medblocks? Any upcoming projects or collaborations if they want to do with you?
Absolutely. Then Siddharth Ramesh, or email me at Siddharth, Sidharth at medblocks.com, medblocks.com. Maybe you can put a link somewhere. They could just reach out to me. I'll be happy to talk to anyone in the digital innovation space. We have a podcast called the Hackers, Digital Health Hackers podcast, where we feature these people who are in the digital health space doing something new and interesting. Would love to hear from you.
Thank you, Dr. Ramesh. This is a fantastic conversation. And to our listeners, if you found this information valuable, you can reach out to him. I will share his links. If you found this valuable, like, subscribe, and share. Let's build a more transparent, efficient, and patient-focused healthcare system in India. Until next time, stay safe, stay informed. Thank you.